Hi everyone, I'm Dr. Russell Sassani. I'm here with my husband Michael and our daughter Lauren. We're visiting the UK for about 12 days and we're here to meet with the FTM group here in London. And I just wanted to talk to you a little bit about the surgical aspects of how we do things in the United States and in Florida. And I have been doing lots of transgender surgery for about 3 to 4 years now. And on a busy week, I do about 9. On a less busy week, I'll do about 5 or 6. So that's sometimes back-to-back surgeries on certain days. But Mike is our surgical administrator in our office and also the administrator of the surgery center. So we're here to answer any questions that you might have. But I thought I would start off by just talking about how we do things in the United States. First of all, there are a couple things that we require prior to someone having surgery. We do follow WPATH guidelines. WPATH is the World Professional Association for Transgender Health. And what they state is that we do need one letter from a licensed mental health counselor saying that you're ready to proceed with the next stage of your transition. So that would be something that you would need to have your surgery. You need 1 letter for top surgery and 2 letters for bottom surgery. We also like to ensure that our patients aren't smoking prior to surgery for at least a month, so that decreases the likelihood of wound healing issues. And so you'd have to be off anything like that. No nicotine patches, no nicotine gum. The next couple things we're going to talk about really are just some of the risks and complications of doing the surgery itself. This is not a very bloody procedure. We only lose a very small amount of blood during the surgery, nothing of any real consequence. The national hematoma rates for this type of operation is about 7%. So about 7 guys out of 100 are going to develop some bleeding under the skin that would need surgery. My hematoma rates are about 3%, so a little bit less than half the national average. We do leave drain.
Plus they're decreasing now that you've moved the drain position.
Right. I used to put the drain sites up near the armpit area, and now I put them down low, so the hematoma rates have really dramatically decreased since I started doing that.
And Leland helped us determine that.
Right.
With New Beginnings.
Right. We do see patients from all over the United States and abroad. For patients that are coming from out of state, we like when they stay at New Beginnings Retreat, which is a local retreat where trans guys will stay to have their surgery and recover for a week after surgery. Leland, who runs the retreat, he's a wonderful guy. He runs it with his wife Bonnie, and they have 2 externs, which are marvelous. And they get you back and forth to the office. They pick you up at the airport. They get you to the office before your surgery for your preoperative visit. They'll pick you up before and after surgery. And the other good thing is that since Leland got his nonprofit designation, he gets all of his food donated by a local restaurant or local supermarket called Trader Joe's. So all of your meals are included as well. So for something that's cheaper than a hotel room staying abroad, you get a nice place to stay, you get your transportation, you get all of your meals. And the other added advantage is that Leland is also a nurse. So if there ever is a problem during your post-operative course, he's there to help take care of you.
Not to mention the camaraderie.
Yes, and it's a great place for guys to go through the surgeries together.
And also family members.
Family members stay with the patients as well, so we highly encourage you to travel with someone as well.
But oftentimes there's connections that are made between the family members as well.
Oh yeah. Well, new friends are made, certainly. We were talking a little bit before about infection risk, and the infection risk typically for an operation like this is about 2%. But in our surgery center, since I opened it 12 years ago, we've never had any surgical infections, so we're pretty proud of that, happy about that. I normally like guys, when they come in for their preoperative visit, to bring some examples of the things that they like and they don't like. So look at a lot of before and after pictures from other surgeons or from my patients, so that we can try to contour the incisions to whatever your liking is. My aesthetic is sort of a gently curving incision that follows the lower border of the pectoralis muscle, and then we reposition the nipple areola along the lateral border of the pectoralis muscle. I'm not a huge fan of straight lines. I don't think straight lines really are very natural. But again, it's really whatever the patient likes. It's all about what your aesthetic is, and we try to accommodate what your aesthetic is at the time of surgery. We do use board-certified anesthesiologists, so a doctor puts you to sleep, a doctor wakes you up. No one does the surgery but me. The anesthesiologist's sole job is to watch your heart and lungs during the surgery to prevent any cardiac or pulmonary problems, and also to monitor for any allergic reactions. And if any of those things do happen, we have all the emergency equipment and medications to fight any reactions that might occur. And what else?
Well, so once again, we have an ambulatory surgical center, which is rarer for a plastic surgeon to have. So we are not doing office-based surgery. we actually have a fully accredited, nationally accredited,
Medicare certified.
Medicare certified. Um, Medicare certified, nationally accredited ambulatory surgical center that has to follow the same onerous guidelines and policies as the hospitals do.
Right.
So unlike office-based surgery that most plastic surgeons are doing, ours is much safer because of all of the stricter criteria that we have to follow. So the patients are in good hands on that side of it.
And we do strive for symmetry to make sure we keep things as equal as possible from side to side. When we do reposition the nipple areola, we're taking exact measurements from the collarbone to the new nipple, from the nipple to the incision, and from the midline to the nipple. And if all three of those numbers match on both sides, then things should stay fairly symmetrical. The drains are in place for about a week. The bandages that we put on right after the surgery stay clean and dry for that first week. You can't get anything wet. And then when you come back for your preoperative visit, we take all the bandages off, we take the drains out, we teach you how to do the dressing changes to the nipple areola. And you'll do those dressing changes for about 2 to 3 weeks until the nipples are completely healed. And then, hi. Hold on 1 second.
And we have a very good staff. Jessica in particular has been dealing with the gender population for about 8 years now, and she acts as the surgical coordinator with the patients. So she's very, very well versed because of all those years doing this. She used to be at Dr. Wagoda's. Dr. Garamoni, I'm sorry.
So after we do your reveal, you'll do the dressing changes for about 2 to 3 weeks, and then you'll continue wrapping your chest for about 4 weeks, and then after that you'll never have to bind or wrap again. One thing that guys are always worried about is revisions. My revision rates are quite low. I'm very conscious and careful because a lot of our patients do come from other states and other countries. So I'm very cautious and careful how things look on the operating room table, so that minimizes the risk of having to do a revision later on, because no one's going to be very readily available to come back, from other countries or other states. But if I have to do a revision, there's never a charge to do a revision. We don't charge for those.
Okay, but some patients he was mentioning might want to come for a revision.
Right, and I have done that in the past. People that have had their surgeries done elsewhere, I will do revisions for them. And we'll try to develop a very, reasonable fee, because you've already paid for the surgery once. Having to pay for another revision is, kind of onerous. Yes.
I was going to say, could you just explain if you get a revision, how easy it would be, or how difficult it would be to correct what you
It really depends. I've had guys where there still is a tremendous amount of breast tissue that's still left behind, and it's almost like doing the operation all over again. If it's just a matter of cutting off a couple dog ears or revising some scars, that's fairly easy to do under local anesthesia. But if it's a major revision, those would have to be done under general anesthesia, so then you have the cost of the operating room and the anesthesiologist all over again, in addition to the surgeon's fee. So when we have done revisions on patients that have come from other places, we do a very thorough phone consultation or Skype consultation, or the patient sends a lot of before and after pictures so that I can see how they look before their surgery, how they look after their surgery, and what I think I can do to help give them a reasonable result. So it really has to be very individualized. I can't give you a definitive fee of how much it would cost to revise without seeing pictures.
Do you want to say anything about your training?
My undergraduate training was at Rutgers College of Pharmacy. That's in New Jersey. And then I went to Rutgers Medical School for 4 years. So I was a pharmacist before I went to medical school, so I knew all the medications before I went to medical school. And I was able to work part-time as a pharmacist while I was in medical school, so I came out of medical school with a lot less debt than a lot of my classmates. And then I did all of my general surgery training and plastic surgery training at the University of Pennsylvania in Philadelphia. And when I finished my plastic surgery training, I went down to the University of Miami and I did a craniofacial fellowship and a cosmetic surgery fellowship. And when I was doing those fellowships in Florida, I decided to stay down in Florida because it was a beautiful place to live. And I stayed in practice there. I've been in practice there for 22 years now. And I've been doing top surgery for about almost 3 years, maybe a little over 3 years.
And so, like we were saying, what lent you to do such a great job with top surgery was all of the breast reconstruction from
Right.
cancer that you had done over the years, for one.
The biggest part of my practice historically, being in practice for 22 years, was breast surgery. So breast reductions, breast lifts, reconstructions particularly. I think the reconstructive aspects of breast surgery really helped me to prepare myself for doing top surgery for sure. So.
I have a question with regard to scarring and stretching. What are your thoughts on what causes scars to stretch more? Because I know a lot of people sort of avoid lifting their arms, but I feel if it's going to stretch, it's
well,
going
a
to
lot of
stretch.
it has to do also with tension.
Yeah.
So if the surgeon takes out too much skin, it has to really close those skin flaps very tightly. There's going to be a natural tendency for the scars to widen. So I'm very careful at the time of surgery to make sure when I pull that upper skin flap down, it's sort of a judgment how tight it is. You don't want to make it overly tight, but at the same time, you don't want to keep it too loose either, because you don't want there to be any skin redundancy either. So it's really a judgment call. I sort of pinch the tissues together before I do the surgery, while the patient's just under anesthesia, and that helps me to guide my preliminary markings where my incisions are going to be. But it really is a judgment call. And then afterwards, no vigorous activities, no running, jogging, heavy lifting for 4 weeks. And then no chest exercises, no chest flies, bench presses, push-ups for 8 weeks. You can reach above your heads after about 2 to 3 weeks, just nothing overly vigorous. So that helps to minimize the scarring as well. And then there are some very good scar gels, silicone-based scar gels, Scar Guard, Scar Fade, Kelacoat. I don't know what the brand names are here in the UK, but the scar gel really has to have silicone in it, because that's really the only thing that's been clinically shown to help keep the scars flat and also to help them fade away a little bit more naturally than they would have gone away on their own.
Can you talk a bit more about how much it costs and what kind of help might be available that you know of for people outside of the US?